I'm Amanda Allen with Stress Free Aging, and we are here today with Assured Hospice. We are here to do some myth busters when it comes to the myths that have been flying out there for years about hospice. So I am a business development representative with Assured Hospice, and I'm here with the administrator of Assured Hospice, Liz Lawson. And so we're going to get right into some of those myths that we have with hospice. So we want to just bust them and kind of get some great information out to our listeners and to anyone that might be struggling at home with a loved one that they're taking care of. So our first myth that's been out there is hospice is a place.
Okay, so hospice is actually care that is delivered in your residence, whether that's a private home, whether that's an assisted living facility. We can go into the skilled nursing facilities, the small group homes, the AFCs. It also can take place in a hospital. In a hospital, though, there's a higher level of care that's required to be in the hospital with hospice.
Okay. The next myth, number 2, is hospice is expensive.
Hospice is actually covered by Medicare and Medicaid. Most insurance providers, your Blue Cross Blue Shields, your Aetnas, your Molinas, those type of insurances also have hospice coverage. Hospice covers things such as medical supplies, dressings, incontinence supplies, your diapers, your wipes, your gloves. If they need lotion on their butt or a dressing for their wound that they have, that's covered by hospice. Medications that are related to the terminal diagnosis, medications for comfort, those are all covered by hospice. Okay. Medical equipment, your hospital bed, a wheelchair, an overbed table, walkers, those are all covered by hospice as well. You receive the services of a nurse, a home health aide, a life coach, and a social worker to help with other issues that might be going on, financial, end-of-life planning, that kind of stuff.
And with Assured Hospice, we also have a wonderful massage therapist.
And a music therapist.
So yes. I think that those are really some great things. I've been a massage therapist for over 25 years, so I know the benefits of massage, and especially for someone that's near end of life.
Well, and with dementia patients in particular, we're finding that he does a cranial massage.
Okay.
And it's really helped with the agitation, reducing the agitation, which is really nice.
That's exciting. That's exciting to hear. The next one is hospice means imminent death.
Okay. Actually, when you come on to hospice, you have to have a diagnosis from a physician that says if this disease follows its natural, normal course, the life expectancy is 6 months or less. That does not mean that somebody's going to die in 6 months. It doesn't mean somebody's going to live for 6 months. It just means that the physician, to the best of his knowledge, is saying that this patient has 6 months or less to live. The fact is that patients who have chosen to be on hospice, actually they have a longer life with a better quality of life. So a hospice, once you decide that you don't want to seek a curative route and you want hospice, then your quality of life gets to be a little bit better.
It has to be better emotionally for the family at that point?
Well, I think we take a burden, emotional burden off, a physical burden off, a spiritual burden off, a financial burden, all help, reduce that stress when you're a caregiver of somebody who is end of life.
Okay. Hospice is painful.
Okay. Hospice doesn't hurt. One of our goals is comfort. Our goal is to keep somebody comfortable, whether it's respiratory, cardiac, just pain. we're not going to cure anything. We're just going to monitor the symptoms and keep you as free from pain as possible.
Okay. Hospice can't be received for a long period of time.
Okay. Well, hospice, we have what we call benefit periods. And those benefit periods are set up by the government, and we have to certify somebody. So as long as there are declines, it can be weight loss, it can be mobility, it can be ambulation, cognitive declines. As long as there are declines and we can document those declines, patients can stay on hospice. We have some patients who've been on for a year, 2 years, sometimes. So it all depends on what's going on with the patient.
So if a hospice patient happens to get better in your care, then they will be taken off hospice?
So, yeah, we have to have a reason to keep somebody onto hospice. The government's not going to pay for what they call custodial care. So when somebody is on hospice and they reach a certain plateau and there's been no declines, and we do what we call a face-to-face visit. So a nurse practitioner or physician comes out and sees the patient and there's been no declines, we have to live discharge somebody. Now, that doesn't mean 2 weeks from when we live discharge you, you may come back because you start to decline. Because a lot of patients get better and flourish and improve with hospice care. They're getting more visits, they're getting more stimulation, the medications are reviewed. So patients sometimes do a little bit better in the beginning, which is why we go ahead and do those recertification periods.
Okay. The next one I wanted to address is hospice and palliative care are the same.
Okay. So hospice, your life expectancy is 6 months or less, according to the physician. You get a team. You get the social worker, the chaplain. You get all those supplies. You get all of that support. With palliative care, you still want to seek aggressive treatment or curative treatment. You still want to go back and forth to the hospital. That's somebody who would be palliative. When you've made that decision, a lot of patients, they're like, I don't want to go back to the hospital anymore. You know, they've been back and forth multiple times. I don't want to go back anymore. That's a hospice patient. Palliative, as long as you want to seek treatment, it's palliative. And with palliative, you get a nurse practitioner or a physician and a social worker. Hospice is more encompassing. It gives you much more support and it covers a lot more than palliative care.
Okay, so I want to use an example of something that came to me recently. It was a phone call that I received last week. Our nurses went out today to see this particular patient and was able to. I know that with palliative, the gentleman that called really could use the help with his wife with bathing and things like that. So then
that's not palliative.
That's not palliative, exactly.
So
I think that that's very important because a lot of people think, oh, well, let me just do palliative. And there are some huge benefits for someone that wants to have more help in the home, less stress on the family, things like that.
Yeah, that's more of the hospice. We're palliative. You're going to be seeking aggressive treatment. You're going back and forth to the physician. Usually by the time somebody gets to palliative, we're like exhausted. We're tired. We don't want to go back to the hospital anymore. We've been there every week for the last 6 months, so.
And this is another thing. So someone that's having a difficult time, let's say they have to see their doctor once or twice a year, but it takes them an hour to get their loved one out of the house and into the car and to the doctors, and it's a big production. That could be a potential consultation for hospice.
Yeah, and the question would be, is it really necessary to continue going to that physician?
So in that case, we might be able to do a home physician or a nurse practitioner or someone, because I know that we've had partnerships with a couple of agencies that we work with. Hospice,
Short shortens.
Oh, it shortens life expectancy.
Okay.
Okay.
So
Hospice shortens life expectancy.
because the goal of hospice is comfort, we're going to come in, we're going to relieve that physical pain, that emotional pain, socially help get resources into the family, some spiritual help. Because you're not using all of your energy and all of your strength to deal with these other issues, your life quality is better and your life expectancy is a little bit longer. So you have a better quality of life and a little bit longer life.
Okay. This is a big one. This is huge for so many different families. Hospice is giving up. As a daughter, I'm giving up on my grandma, my mother. I'm giving up on them.
Okay. So you're not giving up. You're choosing to give somebody a quality of life, a comfortable life. You're choosing to make their last days the best days that you can. And hospice supports not only the patient, but the family, the caregivers. Everybody is included in that circle.
Okay. Choosing comfort care means giving up.
When you choose hospice, you always have the ability to say, I want to stop. I want to go back to the hospital. I want to go and see if there's something more we can do. Even though you're on hospice, you can make that decision. And at that point, we have to do what we call is a revocation. In other words, you've changed your mind. You want to revoke your hospice benefit and go seek aggressive treatment. And that can happen at any time.
Okay.
It's totally up to the family and the patient.
Okay. This is a big one because I don't think people understand that there's other things about this. I'm going to just bring it out there. Hospice is only for people with cancer.
Okay. So nationally wise, because these are the stats I took off the national website, hospice provides 20% of their care to Alzheimer's dementia patients. Okay. Now, in order for somebody to be on hospice with Alzheimer's and dementia, there's a certain level that they have to be at. You know, they can't still be walking. Talking is usually an issue. Language is an issue. Incontinence is an issue. So those patients, once they reach that point, they're appropriate for hospice. 10% of hospice patients have cardiac issues. You know, congestive heart failure, arrhythmias, hypertension, those kind of things. 22% are cancers. 7% are, which I thought was kind of low, especially from what I've seen in our area. 7% have respiratory issues, you know, your COPD, your asthma, bronchitis, those type of things. Those are the things that make people go back and forth to the hospital. So 7% are respiratory, and then there's another 5% of people who have had a stroke and are not recovering, are not participating in PT or OT or speech. So, and then there's a huge percentage that it's 15% actually that come on with malnutrition, which means they're not eating like they used to. You can have somebody who is just eating bites of something. They're losing weight left and right. We can't get them to eat. They don't want to drink. So those are patients that are appropriate for hospice.
Okay, this is another myth out there. Hospice provides 24-hour care.
Okay. Hospice services are what we call intermittent, which means the staff will come in, they're going to do whatever they need to do. If it's an aide, they're going to come in, they're going to do the bathing, the showering, making sure the clothes are clean and that kind of stuff. And then, you know, your nurse comes in, she does her head to toe assessment. So it's intermittent. So they're going to come in, they're going to leave. What hospice has is what's called 24-hour availability. So you get into trouble at 2 o'clock in the morning, you're going to call the on-call or the after-hours number. You're going to get a hospice nurse, at least with Assured. You're going to get a hospice nurse that's going to triage the phone call. She may say, oh, have you tried this? Have you done this? Have you done this? Or she'll make the decision to make a visit. So we do after-hours visits, 2, 3 in the morning. We trot out even in the snow to make those visits, whatever we need to do to keep our patients comfortable and families safe.
Well, once a patient becomes hospice, he or she can no longer receive care from their primary physician.
Ooh, that's a biggie. People think that once I come onto hospice, I have nothing more to do with my attending. That is really wrong. We have a lot of attending physicians who want to follow their patients. They've been with their patients for 20 plus years. They just don't want to walk away. You have some physicians that will do that. Some physicians will say, I want the medical director to take over care. But it's your choice as a patient, and it's up to your physician. If they want to continue to see you, you can still go to the office. You can make those phone calls. So the physician can continue to see.
Okay. You must sign a do not resuscitate order to receive hospice care.
Okay, this is a big one. Okay, so when somebody enters hospice, we know that their life expectancy is 6 months or less. Okay? Now, some families are not ready to say, I don't want a DNR. I don't. Some people are. So you're comfortable. If you're comfortable saying, I don't want mom or dad resuscitated, then you can go ahead and sign the DNR. We don't force you to sign the DNR. It's purely your wish. But that's part of the social worker job, is to work with the patient and the family on advance directives. What does the patient want? We're finding recently that a lot of people haven't had that conversation with their loved ones, and they have no idea what mom wanted, and now mom has dementia and she can't tell you. So that would be, if anything you get out of this, that would be one of the things I would really like to see, is people start having that advanced directive discussion with their family. So, you can be a full code and be on hospice. What would happen is, let's say patient's struggling to breathe and you're uncomfortable. You don't want to call the on-call nurse, who is actually your 911 number. And you decide to call 911, and they take your loved one to the hospital. At that point, then, because you're seeking aggressive treatment, and we talked about it earlier, it's a revocation. You revocate your hospice benefit to go to the hospital. So if you don't revocate your hospice benefit, then you are responsible for that bill. So that's why it's important that you let hospice know whenever you go to the hospital.
Okay. This is a big one. It's hospice care stops at the time the patient passes.
Okay. So part of the hospice team and the philosophy is the loved ones. The loved ones are left after death, and we have a bereavement program. And with bereavement, they get newsletters, they get flyers in the mail. If they need to, they can have one-on-one counseling. They can have support groups. Everybody is different, and it depends where you are on that scale. But we follow patients' families for 13 months after somebody has died.
Okay. I have a couple of questions for you. If one of our listeners are out there and they're deciding what company to go to, I'm asking you specifically, why would they come to Assured? I know they're the best. I know we're the best in the care, and I know that. So why would they choose Assured?
Okay, so I think overall, as a hospice organization, we are very responsive. Even patients that are in your skilled nursing facilities, in your ALFs, even though they have nursing staff there, when we get a call, somebody's in respiratory distress or somebody's not doing well, we will make a visit. So we do get a fast response. I think we have excellent staff. Most of our staff have been with our agency 5, 6, 7 years. Our turnover is very low. And that includes all entities, the nursing, the aide, the chaplains, the social workers. They've all been with me for quite a few years. And I think that says a lot about our team. We have an awesome team, so that when somebody comes on to hospice, in fact, when we do an admission into hospice, we send a social worker and a nurse out at the same time, because families have different questions. They're not just going to be financial questions. They're going to be health questions. So that's why you have to have those two separate entities out there. I also think because we are a smaller hospice, the care we give is more personal. We are one big happy family.
We are.
And that's how we treat our patients, like family.
We do. One of the questions that I have for you is, if someone is out there and they're considering hospice, what do they need to do to contact our office? What do they need to do? What is the process for someone that's seeing this show? It might be someone just sitting at home and they see it on Facebook. Mm-hmm. How can we get them to come?
Well, our telephone number is 248-262-2205. Our office hours are Monday through Friday, 8:30 to 5. You can call the office, and probably 9 times out of 10, you're going to ask for me, and I can help guide. We'll ask some questions like, what's going on? What are the changes have been? What do you want? And then we can guide you. Do you have a physician? Get a physician order. We'll set up a date and a time. We'll do informational meetings without a physician order, just to inform the family of what hospice is and whether or not we think we could help. We'll do evals on patients. If they're in a facility, sometimes we have to get a order so that we can look in the chart and that kind of stuff. Okay. But if it's a home care patient, we can come out to your home and talk to you and give you information and do an evaluation.
Okay. We have another guest that's going to come in for just a moment to wrap up our show. And I'm really excited to have Faye Laporte with us. She is going to just tell us a little bit about her experience with hospice, because one of the things that we spoke about earlier is that sometimes people wait too late for hospice.
Mm-hmm.
Many times it's way too late. So, Faye, can you tell us your experience with hospice?
I've actually had 2. One was my mother, who was in the hospital, but we didn't have hospice. It had never been suggested. And as I could see, I was putting her through all this horrible stuff. They were constantly taking tests, poking her for blood. And eventually I said, I want the hospice, which was at the end. I wished I would have done it sooner. She wouldn't have had to go through all that. The second was a girlfriend, a very close one. And the hospital insisted that she use their hospice. And I talked to her. I said, don't do that. We want her at home with the family. It's totally different. And I suggested a hospice company that had the music and everything, and it made such a difference. I swear she lived longer because she was so comfortable. Mm-hmm. And they would bring the guitar and the whole family was there. I would definitely do it that way.
Yeah. Okay. And most people want to die in their own home. Yeah. They want to die with family and loved ones around them. Mm-hmm. They don't want to die in a hospital all alone with nobody there.
And that brings us to the point that you have a choice. Mm-hmm. So if somebody is out there and you're thinking of hospice, you can call who you would like.
You should call and ask a question. Just ask the question. The person on the other end of the line should be able to get some information from you that can guide you as to what you should do next.
Okay. Mm-hmm. I thank both of you for being on the show.
Yeah, thank you.
Thank you, Liz. Thank you, Faye.
Thank you.
It's very exciting. stay tuned because we do have another show coming up, and it'll be soon. We're going to talk a little bit more about dementia, which is one of those hospice diagnoses. So thank you. Goodbye, everyone.
Thank you.
Goodbye.